Welcome everyone to Chapter 94 Mended Hearts monthly meeting. We're thrilled that you're with us tonight, especially those of you that have never joined us in the past for any of these informational sessions. We're thrilled that you have found us, and we're thrilled that you've been able to log on without any difficulties. My name is Karen. I'm officially the secretary, but I wear a lot of different hats, as most of us do, most of your officers. Just want to remind you all the attendees tonight, that this session is recorded. That means any questions that you either share with us verbally or through the chat. I'll be monitoring the chat as well. But any questions, everything will be recorded. So if you don't want to be on the screen, you can turn your camera off and still hear the presentation. And I'd like to introduce you to Dr. Ahmad. He is the Assistant Professor of Medicine with the Division of Cardiology for Johns Hopkins Community Physicians in Bethesda. He's a cardiac electrophysiologist. He sees patients for Johns Hopkins in Baltimore, at Suburban, and at Sibley. He has an expertise in arrhythmia management and complex ablation procedures, including both atrial and ventricular catheter ablation. He earned his medical degree from the University of Toledo. He completed a residency in internal medicine at the University of Arizona, followed by fellowships in cardiology and in electrophysiology. He is a member of the American College of Cardiology and the American Heart Association, as well as the Heart Rhythm Society. So Dr. Ahmad, welcome. We are thrilled and excited. Our hearts are beating very rapidly now to learn everything about AFib.
Well, thank you for having me. It's a pleasure to be here today. I'm looking forward to talking about, specifically today, a little bit towards atrial fibrillation. But if there are any questions for any other heart arrhythmias, I'm more than happy to answer those as well too. And I think we'll get going. So I'm going to share my screen. This is a brief presentation that I have, because I wanted to gear this towards any questions that you guys all had, so we can answer them and have plenty of time to do that as well. So I'm going to go ahead and share my screen. So thank you for the lovely introduction, Karen. Like I said, I'm Dr. Ahmad, originally from Seattle, and now I'm here in the DC area, but I am in charge of the complex arrhythmia management program that we're trying to build up in Sibley and Suburban Hospital, mainly Suburban though. And today we're going to be talking about what to watch for with atrial fibrillation, and briefly other advances in cardiology and specifically in electrophysiology. So I'll get going on that. So essentially, what is electrophysiology? Well, what we're doing is essentially dealing with the electrical conduction of the heart, essentially. And we treat fast and slow heart rhythms. And maybe you've heard these terms before in the past. A slow heart rhythm is referred to as bradycardia, and a fast heart rhythm is referred to as tachycardia. And we'll be talking about treatments kind of related to both, and then how we can use them for the management of atrial fibrillation as well, which is the most common heart rhythm issue in the country, essentially, actually in the world. So really, first of all, what can we do for a slow heart rhythm? A lot of times atrial fibrillation sometimes can be triggered by a slow heart rhythm. So traditionally, we would put what we call a transvenous pacemaker here. And what you see are two wires, typically two wires, but sometimes even three wires, depending on the situation, going from the blood vessels along the shoulder down into the heart themselves in different locations in order to effectively pace those different areas of the heart. The one picture in the middle, you can see a little bright coil in two different spots, one within the heart itself, and the other one within kind of the blood vessel right here. I don't know if let me see if I can share that real quick with the laser pointer. Right here, there's one coil right there, and there's another coil right there. And this is what we call a biventricular device. So in here, there's effectively three wires highlighted by these arrows. So one right here in the top chamber of the heart called the atrium, and then two in the bottom chambers of the heart called the ventricles. And this one here is a defibrillator coil as well too. So new technology has been, advances in medicine in general, and especially in electrophysiology have come along. And it's been a great time to be an electrophysiologist, because we have all the tools kind of that we need. Chips and stuff like that have made it very, very easy for us to be able to do things that we thought were just science fiction in the past. And now we are able to do things that I don't think people could have thought of that we could have done even 20 years ago, let alone 10 years ago. So the first thing I'll be talking about is the addition of what we call leadless pacemakers. Why leadless pacemakers? Well, we avoid the wires that directly go into the heart, which can sometimes cause issues later on. I think some members in the audience can attest to that as well too. And so the benefit of leadless pacemakers, you don't have any wires, and it lasts for anywhere from 15 to 20 years, typically depending on the usage of the device. The benefit for this is mainly in patients who have long-standing persistent atrial fibrillation or permanent atrial fibrillation, where really what we're trying to do is pace the bottom chamber of the heart called the ventricle, while the top part of the heart just kind of goes away in atrial fibrillation. It's kind of a last-ditch effort to keep the heart rate up and keep the patient asymptomatic from having a low heart rate. It's very easy to deploy, and long-term care is very, very minimal. You know, with the wires, sometimes it can be a higher risk for infection, and so we put these in patients who might be at higher risk for infections, whether they're due to chronic kidney disease and they're on dialysis or other such things as well too, or they've had a history of bloodstream infections in the past. For these patients, the leadless pacemaker would be a better option because they can avoid the possible need for the wires getting infected and possibly having to remove the entire device, which becomes an issue later on in a much larger procedure as well too. And likely this will be the future of pacing technology, you know, once we work out a few things here and there. So we're very excited to have all the pacemaking technology at Suburban Hospital in the local area. Here are the two different types of leadless pacemakers. The one on the top is made by the company Medtronic. It's called a micro device, and it's deployed by a sheath that goes from the femoral vein, which is the blood vessels near the groin. As you can see here, it's about the size of a nickel essentially. And it kind of just gets deployed in what we call the right ventricle of the heart. And then there's a little wire, and when we release the wire, and the device is deployed essentially after the numbers have been established and are kind of satisfactory at that point. Then we go ahead and remove the sheath, and then I usually employ a suture at the groin site to control any kind of bleeding once we remove the sheath. Usually patients are pretty comfortable afterwards. They only have to lay flat for a few hours. And then afterwards, they're kind of able to go in without any kind of restrictions with arm conditions or kind of avoiding water contact, because a traditional pacemaker, you have to make an incision along the shoulder. And that can be sometimes a risk for bleeding, bruising, hematoma, as well as infection. The one on the bottom, we're very excited to now have or be able to soon employ, is the Avere device by St. Jude or Abbott nowadays. And what you can see there are two different sizes, and the two different sizes correlate to the ability to put the larger one in the right ventricle, just like in this device. But then we're also able to employ a second device in the top chamber of the heart, and we can effectively pace the heart as close to normal physiology as possible, which can be beneficial, especially in the setting of atrial fibrillation. Like I said, sometimes a lot of patients who have atrial fibrillation tend to have a higher risk for needing a pacemaker for various reasons, whether it's something called AV block, where there's a lack of heart conduction between the top part of the heart to the bottom part of the heart, or if it's due to something called sinus node dysfunction, where the main pacemaker cell of the heart is just affected and not working as effectively. And so there are multiple reasons for needing a pacemaker, and it's good to have all these options available that we didn't really have in the past. And you can see here, so we have a side-by-side comparison. Here's the device generator for the traditional pacemaker. There's two wires going into the blood vessel of the heart. Typically, I mean, the way I put a pacemaker isn't this low. It's usually a little bit higher. And then what you do is you have wires going down. One's going into the top part of the heart called the atrium right here, as you can see by the arrow. And then another one going to the bottom chamber of the heart right here as well too. And look how all that is replaced by just this little tiny device right in the corner here. And eventually there'll be another one right around here too, to effectively pace in a similar manner as these two wires. As you can see, it's a lot less bulky, and the chance of infection is very, very low compared to a traditional pacemaker. So we're excited about that technology to be available at Suburban soon. Now, treating heart fast rates. So in this, we're talking about anything from supraventricular tachycardia to mainly what I treat in my expertise, which is atrial fibrillation, which is the most common heart arrhythmia in the world. The reason why we get concerned about atrial fibrillation is that it increases the risk of stroke, congestive heart failure, and even vascular dementia has been reported increasingly in the last 10 years in literature as well too, plus or minus the symptoms that patients have as well too. So all those things highlight the need for effective management of atrial fibrillation. So in the past, main treatment stay was medications of some type, whether it was to control the heart rate or whether it was to control the heart rhythm. There were two strategies, rate control strategy and the rhythm control strategy. Well, a lot of the medications, especially the ones that control the heart rhythm, were what we call antiarrhythmics, were noted to have multiple side effects. And the one kind of most common medication we use probably in when it comes to heart rhythm control in the hospital, especially, is something called amiodarone. And now amiodarone is a great medication, but it does have extensive side effects. And so one of them is that it can affect the thyroid. The other one is it can cause liver toxicity. It can cause pulmonary fibrosis potentially and cataracts, as well as, if you can see this gentleman here, I didn't put him there for no reason. He's actually someone who's been on amiodarone for quite some time now. And due to the medication reaction with the skin in the setting of the sun, his skin has turned effectively gray-blue. So he kind of looks, for lack of a better term, a Smurf, I guess, is what I would say. And then lastly is electrically shocking the heart, which essentially is a stopgap measure. I mean, it's usually just to temporarily fix the issue, but it doesn't treat the underlying cause for the atrial fibrillation, which is good in certain situations, but it also means that the patient can go right back into atrial fibrillation. There's nothing stopping that as well, too. So atrial fibrillation, like I said, is the most common sustained cardiac arrhythmia in the world. The irregular heart rhythm, which can increase your risk of stroke, heart failure, and even dementia, as well as the tremendous emotional and financial burden that you see with regards to treatment of this situation. I mean, every time you have to get cardioversion, you have to go into the hospital. It requires an anesthesiologist or some kind of sedation protocol. Afterwards, the patient has to go home and someone has to drive them. So they have to arrange for that, all that as well too. As well as just some people just have significant symptoms and they can't tolerate the palpitations as well, or their shortness of breath, they have chest pain potentially, or they may even be passing out or near passing out as well too with atrial fibrillation. So there's a whole host of things that can occur in the setting of atrial fibrillation. And, you know, I see patients tear up in my clinic quite often because they just don't want to deal with it anymore. And as much as it may not be immediately life-threatening, long-term, it can cause significant comorbidities as well too. And so those are the reasons why we're taking atrial fibrillation a little bit more seriously than we were back in the past. So this is kind of the outline of a typical patient who has a history of atrial fibrillation. Now, that withstanding, atrial fibrillation is a progressive disease. There is no true cure for it. But what we're trying to do with all our therapies is to prevent progression to what we call persistent or even permanent atrial fibrillation, where the risk of all these side effects is higher. The need for medications might be more, and the potential for side effects as great as well too. And as we get older, you know, we tend to be on more medications, and then there could be interactions between the medications, especially that one medication, amiodarone, seems to interact with almost everything. So it's kind of important to try to avoid all those things as much as possible with regards to treatment of atrial fibrillation. So as you can see here, there's probably a few when you're a little bit younger, you know, 30s, 40s, you have probably a little bit of AFib, but you don't really notice it here and there until you have a more sustained episode. And this is, you know, the time of first diagnosis. And then ever since then, you have a paroxysmal presentation, meaning you go in and out of atrial fibrillation. But when you go in atrial fibrillation, the episodes don't last more than 7 days. And that's kind of the classification system we tended to use in the past. Now we're trying to employ a more succinct and objective measure for the management of atrial fibrillation and diagnosis. But as of right now, the previous ones that we used were paroxysmal atrial fibrillation, like I said, for less than 7 days. Persistent atrial fibrillation then is a progression of the disease state. And now we're in atrial fibrillation for longer than 7 days, or up to 1 year technically, or that you've required an electrical cardioversion. That's what these lightning bolts are demonstrating. And as you can see, you have a cardioversion, but then you have another blip, and then another more sustained blip, and then you're in AFib for much longer, and then you have a cardioversion, but then it's not lasting as long anymore. and then you may have a relatively free period, and then you kind of progress even further. And even in permanent atrial fibrillation, even when you do a cardioversion, essentially you don't stay in normal rhythm for that much time anyways. So what we want to do is prevent progression from paroxysmal to persistence, and we definitely want to prevent progression to permanent as much as possible. And I think we're starting to notice that if we can do that earlier on, and meaning treatment and being more aggressive earlier on, especially in certain patients, that we can prevent the progression of atrial fibrillation to a more persistent and permanent state, and then just keep patients in a more paroxysmal state, which is much more livable than being in persistent or permanent. Though there are patients out there that seem to do okay being in AFib all the time. So what causes atrial fibrillation? Well, there's lone atrial fibrillation. There is a genetic component, but we don't have any genetic targeted treatment therapies for that as of yet. So most of the time it's due to something else. I would say, anywhere from 80 to 90% of the time, atrial fibrillation is usually due to some environmental triggers. So in this situation, high blood pressure, patients who have obstructive sleep apnea tend to have a correlation, a positive correlation with having the sleep apnea and atrial fibrillation. So management with either a CPAP or some kind of device in order to prevent the apneic episodes can be helpful in these situations. Patients who are overweight because of all the pressure on their heart and the lungs tend to manifest atrial fibrillation as well too. Patients who have heart failure, it's kind of the chicken or the egg. Does the heart failure or the weakened heart muscle lead to atrial fibrillation, or is it the atrial fibrillation that leads to the weakening of the heart muscle? It can be in either circumstance as well too. Patients with valvular disease, especially any kind of mitral valve disease, tend to have higher rates of developing atrial fibrillation. The reason is because atrial fibrillation comes from the left atrium, and the mitral valve is a left-sided valve essentially for the most part. Alcohol, so a holiday heart, which is that picture up there. So you might have felt it, while you were younger in college. You go out for a drink, and then the next morning you'd feel your heart palpitate. That could have been an early manifestation of atrial fibrillation, essentially. And lastly, any kind of metabolic disorders such as the thyroid, whether it's high or low. Typically, high thyroid is a little bit more difficult to control, and the treatment for that is actually treatment of the thyroid itself versus treatment of the atrial fibrillation. So like I said, one of the things that we like to prevent as much as possible is a stroke. And so there are different therapies that we can employ. First of all, we need to do a risk stratification, meaning what are the risk factors associated with the stroke in the setting of atrial fibrillation, and whether or not they need to be on a medication such as an anticoagulant. Historically, in the past, Coumadin or warfarin was the mainstay therapy for blood thinning. But in the last decade or so, or even more, there have been what we call the novel oral anticoagulants. You might have heard them, anywhere from apixaban or Eliquis to Xarelto, as well too. Those are kind of the more common ones that are there, as well as Pradaxa and Edoxaban. They're making more and more blood thinners as we go along. They are relatively expensive medications, but hopefully in the next few years, they should be having more generic ones coming out, and that'll be a major game changer with regards to the financial burden of atrial fibrillation. The other option is a surgical therapy. So we can employ a device from a similar approach through the femoral vein of the groin, and go up with a sheath from the right side of the heart here, cross into the left side of the heart here. This structure right here is called the left atrial appendage. It's kind of a remnant of embryology, but it's still there. And this is where, in the setting of atrial fibrillation, most of the blood clots form, essentially. And so what we can do is employ a device that's kind of like a plug that goes into this area in order to help patients eventually get off a blood thinner if possible. Now, not every patient right now is a candidate for these devices. Certain patients who are at higher risk for falls, patients who are at higher risk for bleeding or have had a major bleed tend to be the ones that we like to focus to place. But there are patients who just don't want to be on a blood thinner, and if there is an indication, we can try to see if that's allowed or not. But for the most part, it's a good device. Either of them. There's two main ones right now. One is the Amulet device that's made by Abbott. And then this kind of has this bilobe structure right here. So there's one deeper end, and then there's the little cup that sits on top over the opening of the left atrial appendage. And then secondly, and the most probably commonly used is the one from Boston Scientific, and this is called the Watchman, which is on its third or even fourth iteration at this point. And it's probably the most commonly implanted left atrial appendage occlusion device, as we call them, in the world as of this moment. And we put these in at Suburban as well. Now I'm kind of shifting forward towards the reason why I'm here in the area, which is catheter ablation, which is where we take catheters into the heart and we either through radio frequency or through freezing balloon cause change and kind of program cell death, essentially, or cell death actually, of certain areas of the heart in order to prevent heart arrhythmias from occurring, essentially. And so these are the different types of catheters that we employ. Most of these are kind of what we call mapping catheters, essentially, and these help us create a high density map. The pen array is now gone. They have that since replaced it with the oct array, so now it has 8 splines, as the name says. We have the HD grid, which is another type of mapping catheter as well too, and the Orion catheter. They're all for different mapping systems, essentially. And what that provides us is a real-time 3D shell that we make of the anatomy of different areas of the heart that we can use to see structurally, to decrease the risk of fluoroirradiation use as well too. And we also can collect the electrical data as how the heart conducts during either a heart arrhythmia or just during what we call a normal rhythm as well too. And we can see the propagation of the electrical activity through the heart, which is really, really cool. This is the ablation catheter itself. There are different types of ablation catheters. This is what we call a radio frequency or burning catheter, essentially. And it has little irrigation ports at the end to keep the flush going because we want to prevent clots from forming as we ablate. And this tip right here is connected to a generator, which then employs the radio frequency, and we cause burns to occur as well too. Here we have the newest type of catheter that's going to come out soon. It's called the Pulse Select by Medtronic, and it's what we call pulse field ablation, something that we'll talk about later in this presentation as well too. And that's going to really change the game with regards to AFib, we're hoping, especially in the management of other heart arrhythmias in the future. So these are the maps that we make, the real-time 3D maps that we make. This one right here is what we call the left atrium. And this is primarily where atrial fibrillation comes from. Specifically, as you can see here, the 4 pulmonary veins. The pulmonary veins seem to be the source of atrial fibrillation in about 90% of patients. And so in order to effectively ablate the atrial fibrillation, what we do is we encircle the veins on both sides, the right and left side. So this is the left side right here, and this is the right side right here. In order to isolate electrically the signal for the AFib to permeate into the heart, essentially. This is the same left atrium right here, just a different view of a different heart arrhythmia, as well as this is the bottom chambers of the heart, the ventricles, and sometimes you can have a ventricular arrhythmia that needs to be ablated, whether it's a single pinpoint, something called a premature ventricular complex, or something more life-threatening, such as ventricular tachycardia, which is a very fast heart rhythm coming from the bottom chambers of the heart, which can lead to sudden cardiac death. And so we can do a procedure called an ablation in order to help try to prevent those episodes from happening as much as possible. So what is the history of ablation with regards to treatment for atrial fibrillation specifically? So there have been multiple randomized controlled trials studying atrial fibrillation and the effect that ablation can have on it. You have anything that are comparing antiarrhythmics to catheter ablation. You have ablation versus antiarrhythmics for first-line therapy of symptomatic AFib patients. These are one of the first trials out there as well too. And then using what we call rhythm control therapy in patients with atrial fibrillation. This is another study, the East AFNet 4 trial, which in itself was comparing ablation to other typical therapies with regards to atrial fibrillation. These have all kind of hinted towards and pointing towards this, benefit of atrial fibrillation for the management of atrial fibrillation. And now with the most recent guidelines that were published just in December of 2023, by the American College of Cardiology, the American Heart Association, the Heart Rhythm Society for the management of atrial fibrillation. It's become essentially a class 1 indication for the management of atrial fibrillation, which is an ablation, a cardiac ablation, especially in patients who are symptomatic or patients who have congestive heart failure as well too. It seems to be very beneficial in these patient populations, though we continue to do more and more studies in order to see what outcomes we can have as well too. So what is the argument for ablation? Well, this is one of the figures from one of the trials. And as you can see, if you ever come see me in clinic, I talk about the 90-day blanking period. So whenever you're effectively ablating the left atrium, especially a complex arrhythmia like atrial fibrillation can be complex. And due to that, there is no immediate cessation of the heart arrhythmia, the atrial fibrillation. It takes some time for the tissue to heal. It's kind of like the analogy I use for my patients, like having a cut on the hand. At first, it's kind of red and ugly and inflamed, and then over a few weeks, it kind of heals over, scabs over, and heals, and then it scars, and that's what happens in the heart essentially. So we have to give that about a 90-day blanking period, or what we call kind of up in Hopkins the healing phase as well too. So what these do is that for that 90 days, we don't really record any data, whether or not you go into AFib or not. You're at high risk because of the inflammation generated by that. So we don't really take that data into account. Once the tissue has healed, we take data from that. And what we see in the red line is traditional drug therapy. And what we see in the blue line is the ablation therapy. And you can see that at over a year, and these studies were much older. Now there have been more recent studies done that go out even 3 years, that ablative therapy is superior to even drug therapy long-term for the management of atrial fibrillation. That's why in a procedure that is as safe and effective as an AFib ablation, we're starting to recommend that as first-line therapy as electrophysiologists for the management of atrial fibrillation compared to drug therapy, since it has become very, very safe and effective. So the main types of catheters, like I said, the bottom here is the radiofrequency ablation. So you're kind of doing point by point, or what I call tack welding essentially, and you're going around each area, which are the openings right here are the openings of the pulmonary veins. And then this right here is the cryoballoon catheter. And so essentially it's a freezing catheter. So this is a mapping catheter that collects the electrical data in the vein. And then what you do is you position the cryoballoon at the opening of the vein right here, the ostium, and you apply different zones of freezing to the veins in order to effectively isolate them from the rest of the heart, essentially. So both procedures are fairly safe and effective, and they're both pretty comparable with regards to the management of atrial fibrillation, though there has been recent studies out of Canada which demonstrated that radiofrequency tends to prevent the progression to more persistent or states of atrial fibrillation better than cryoballoon. But in the setting of paroxysmal atrial fibrillation or persistent atrial fibrillation, they're both pretty effective therapies nonetheless. And now this is kind of the exciting part. Well, what's going on in the future? Well, this right here is the newest catheter. This one specifically is coming from Boston Scientific, and it's called FARAPulse. And what it is pulse field ablation. So pulse field ablation has been around for quite some time, actually, but it's never been applied in this situation before for the ablation of atrial fibrillation or other cardiac arrhythmias in the heart. Now, the nice thing about pulse field ablation is that it can be attuned to be tissue specific. So what we can do is ablate tissue of the heart without causing significant damage to structures that are next to the heart, such as the esophagus or other things as well too. So we can kind of prevent damage to that or the nerve structures that innervate the diaphragm, the main breathing muscle of the heart, called the phrenic nerve as well too, which can be damaged in various types of ablation. So we have to be careful for those. And this kind of prevents the need for that because it doesn't cause a lot of peripheral damage essentially. Whereas if you see in these figures right here, radiofrequency, and this right here is the esophagus, and this right here is the phrenic nerve, you're at higher risk for damaging these structures, including even with the cryoballoon as well too, which can cause an atrioesophageal fistula, which is a very life-threatening emergency or the phrenic nerve as well too. But here you see with the pulse field ablation, it's very specific to the tissue of the heart, but it leaves the phrenic nerve and the esophagus and other peripheral structures relatively intact without any significant damage. So we can ablate a lot longer, probably more effectively, and kind of not without disregard, but be kind of certain that our ablations aren't causing as much peripheral damage as they could in the past. And so it's going to be an amazing technology, and we're lucky that hopefully in the next year or so we'll get our own generator down here at Suburban, but we're starting to play with it up in Baltimore, and it's been fun to be able to employ the catheters there. And then lastly, this is kind of a picture. This is me actually doing an ablation live. And see if this video plays. I don't know if it will or not. Oops, sorry. Just probably play it like this. It doesn't work. There we go. And so what we see here is the left atrium here, like I said, for atrial fibrillation. These are those pulmonary veins right here in the corners. Let me put the pointer back on and see if that helps. So these are the pulmonary veins right here. And we're looking at the heart from the back. So this is a representative of the patient's posterior end. And what you see here are all the dots are all the previous ablation points. This is a mapping catheter that's in the heart at the time recording the electrical data. And this erratic nature right here, as you can see, is reminiscent of atrial fibrillation, essentially. And so what we're going to do is, let me get rid of the laser pointer at this point. So I'm going to go ahead and play the video. And what we're going to see is as I'm ablating this last area right here, the AFib goes away, and now you have a nice normal heart rhythm. Doom, doom, doom. And that it's pretty much regular compared to how erratic it was earlier. And that's the benefit of an atrial fibrillation ablation, essentially. Now, do we get those results with everybody? Not necessarily, but like I said, it is a safe, effective procedure, and we do them fairly commonly now down here at Suburban Hospital. So with that being said, I'm open to any questions at this time.
I just have one question in the chat, but then we'll just be very informal. So if you all have any questions, we'll just let you ask them directly. But Craig is asking, he's making the comment that he knows a lot of people that never knew they even had AFib. Mm-hmm. And what are some of the most common symptoms of AFib?
So that patient population is kind of, from my end, a little scary because you don't know you have the symptoms. And like I said, one of the most common complications that can arise from atrial fibrillation is a stroke. So you might actually present with a stroke. A lot of patients that come in for a stroke of unknown etiology, we even employ various monitors such as a Holter monitor or an implantable loop recorder in order to see if they do have a nascent atrial fibrillation that's just been undiagnosed. So out of the patient population, roughly the numbers are people who have a stroke of unknown etiology, about 30 to 40% of those patients tend to end up having atrial fibrillation as the source. So in that regards, yes, it is concerning that, that patient population specifically is out there, and we do the best we can. Luckily, with the employment of wearable devices such as, and I don't have any shares in these companies, but an iWatch or a Cardiac or anything like that, that can really help in the diagnosis of atrial fibrillation earlier on before they manifest some kind of tragic complication such as a stroke.
Thank you. Carol is asking, what is the difference between AFib and throwing PVCs?
So they're actually in two different parts of the heart. Atrial fibrillation is in the top part of the heart called the atrium. It's an irregular heart rhythm that's there consistently. It's what we call irregularly irregular. Throwing PVCs, on the other hand, comes from the bottom chambers of the heart, the main pumps of the heart called the ventricles. And what it is typically point by point areas within that chamber of the heart that's just misfiring uncontrollably. And it can be for various reasons. It can be for calcium channel dysregulation, or it could be there's some kind of irritation. It could have been from a previous heart attack, or it could be from uncontrolled blood pressure issues, hypertension, sometimes even rarely sleep apnea as well too.
And then if I can just kind of tag on to Carol's question, what about flutter? Tell me a little bit about that.
So atrial flutter is essentially a circuit in the heart. And it is, I call it the cousin of atrial fibrillation because it can still manifest the same complications that can arise with atrial fibrillation. And that's stroke, congestive heart failure potentially as well too. So with regards to atrial flutter, it's usually a much more easier ablation than atrial fibrillation for the most part. So there's two different types for everyone to know about. There's usually typical atrial flutter and there's atypical atrial flutter. Typical atrial flutter is usually on the right side of the heart, and it is a fairly easy ablation to do. Typically takes me about 30 to 45 minutes to do an atrial flutter ablation, versus an AFib ablation, which takes me anywhere from an hour to 2 hours, depending on the situation, because it's a more complex procedure. That being said, like I said, they're cousins of each other, but a flutter ablation typically is easier to ablate because what you're trying to do is just put a little line somewhere in order to prevent the circuit from going. So you kind of put it like a circuit breaker in with the ablation versus the AFib, where you have to kind of go around those pulmonary veins. You can have atypical flutters, and that can be anything that's not truly a specific right-sided atrial flutter, essentially. 85% of the time they're typical, so it's kind of easier to treat that way. It's usually a same-day procedure too. AFib ablation is also a same-day procedure as well too, for the most part. I would say 95 to 97% of my patients go home the same day.
And same with cardioversions, right? They're usually outpatient.
Cardioversions, they're typically outpatient for the most part. We do employ inpatient ones in case we have a very sick patient with atrial fibrillation and it's been difficult to control just with medications. We can go ahead and do a cardioversion, but a cardioversion is just applying pads to the chest, putting the patient under sedation, making sure that they're pain-free and they're not awake, because no one wants to get shocked while they're awake. And then what we do is apply a jolt of energy between the pads in order to kind of stop the heart and then let it restart into normal rhythm, hopefully. Now, does it work all the time? No, it works most of the time. But when it does work, it keeps the patient relatively out of atrial fibrillation or atrial flutter or any other type of arrhythmia potentially for quite some time. But it's not a treatment for it in the sense that it's a pure permanent cure, because every time you get it, you have to go back and get the cardioversion done. That we try to prevent with the use of medications or possibly the need for a pacemaker or ablations, which I think are probably the way I tend to go, at least. So.
Anybody else have any questions? I can tell you guys are thinking hard.
Okay, I got one. Can y'all hear me now?
Yes, Brian. Yes, yes.
All right. At what point does a slow heart rate have anything to do with AFib?
So that's a great question. So sometimes when your heart rate's a little too low, the heart may kind of freak out and be like, well, I need to do something in order to make sure that blood flows. And so intrinsically, it will go into atrial fibrillation potentially. And in some patients, having a pacemaker in those patients, it can kind of help prevent those lower heart rates, which could be a source for patients going into atrial fibrillation. A lot of times you may notice that you go into atrial fibrillation while you're sleeping. Well, the heart rate that you're going to have that's the lowest is typically while you're sleeping, because your body doesn't have the demands on it that it needs in order to have a higher heart rate. So wouldn't be surprised if patients have as low of a heart rate as 30s or 40s, which in that situation, as long as you're asymptomatic and not having any symptoms, is a normal heart rate. When I see that, and my patients get concerned all the time, they're like, oh, it has to be 60, it has to be 60. No, that's just a definition that we've come up with for a normal heart rate. And right now, the normal heart rate ranges anywhere from 50 beats a minute to 100 beats a minute. That being said, 90 is a normal heart rate as well, too. And I think sometimes I need to remind that to patients is that, yes, your heart rate's in the 90s doesn't mean, just because it's going faster than 60, that you're going to wear out the heart more than you are when it's at 60. There's been no real data showing that that's the case. Most of the time when we're talking about atrial fibrillation prevention, the sweet spot that we've seen is somewhere around the heart rate between 65 to 80 in order to decrease the chance of AFib from happening. So if you have too low of a heart rate, you have a higher risk of developing atrial fibrillation. If you have too high of a heart rate, you have a higher risk. So patients who are very sedentary and not very well conditioned, are at higher chances of developing atrial fibrillation, which makes sense. But then the other patient population, which is the athlete's heart, is also at higher risk for atrial fibrillation. I think, there have been many athletes out there, Kareem Abdul-Jabbar, who's doing commercials for blood thinners right now, and or JJ Watt, who's a football player who had to retire because he had to be on a blood thinner, essentially because of the diagnosis of atrial fibrillation. So I mean, those are world-class athletes, and they have atrial fibrillation. What makes them different than anyone else is that they have a very well-conditioned heart that they've kind of stressed too much. So you have to find that balance of not stressing your heart too much, but also stressing your heart enough so that it's healthy as well too. And it's finding that nice balance between both.
One more. Does the body ever reject the ablation or not? It doesn't necessarily like it per se?
The body?
The body or the heart itself?
No, so we don't leave anything in the body with regards to the ablation. There's nothing left in, that the heart would react to. And usually the catheters that we use are fairly safe for the body. So I've never heard of a situation where there's a negative reaction by the body, some kind of response due to having catheters within the heart itself. Maybe it's out there, but it probably is a very rare case report or something like that.
Okay.
Anybody else?
Yeah, Karen, I have a question.
Jeff.
First off, you took my question about flutter versus AFib. Because years ago, 6-7 years ago, that's what I was diagnosed with, A-flutter. Doctor, more comment versus a question. Being an individual that's been on a blood thinner now for 40 years, I just passed my 40th anniversary last week. I always try to tend to try to find a positive in everything. And I was being on a blood thinner for 40 years, certainly it's had its complications. But whenever I slightly go into AFib, I think at least I'm covered with not getting a stroke. Is that true?
Yeah, so if we look at kind of graphs of atrial fibrillation and being on a blood thinner or not being on a blood thinner, so at the lower end is just anyone who doesn't have AFib. And so their risk increases over time, regardless of whatever disease state they have. Then you have patients with atrial fibrillation not on a blood thinner like that. And then patients with atrial fibrillation on a blood thinner. As you can tell, it's a little bit on the lower end. It's not completely back to normal because they have the AFib, but it's a lower percentage than not being on a blood thinner. So in that term, I have my dad on a blood thinner because he has atrial fibrillation. So and if you can tolerate it, I think it's a great medication to be on. In order to prevent various things such as a stroke, which is very, very important, and it's a big cost to the United States population. On anywhere from sometimes you hear $80 to $300 billion cost total, if you include like rehab and things like that the patient will have to go to in some kind of care facility long term. So it's definitely a cost drainage, and if we can prevent events from happening as much as possible, whether it's just a medication such as a blood thinner, or if it's preventing the AFib from happening as well with medications, pacemakers, or an ablation. I think all those things, if we do those things right now, they kind of decrease the cost long term by decreasing the chance of you developing those side effects and potential complications that can arise from atrial fibrillation. So yes.
One other question along the ablation line. What percentage of people have to have it a second and or third time after you ablate the first time?
So great question. First of all, it depends on the flavor of atrial fibrillation that you have. So if you have kind of the more mild form, or what we call paroxysmal, you have a better chance of having a better long-term result. So if you look at the most current trials, it's usually around 75 to 85% for paroxysmal AFib. Some centers would even say even almost 90% preventing AFib or significant AFib at about 3 years. And does that mean, once 3 years happens, the ablation goes away, the effect of the ablation goes away? No, that's just how long the studies are paid for and covered. That's all it is. So if you take that into account, I've personally had patients 5 or 10 years after an ablation who've done very, very well. And what is a good result from AFib ablation? Well, it might not be that we get rid of AFib completely, but if you were having AFib at 20%, 30%, 40%, or 50% burden, some are even in AFib all the time almost, and we can reduce that to less than 5%, even less than 1%, you might have short runs of AFib, but they're highly tolerable and you can live with that versus being in AFib all the time or much longer because of the wherewithal. The longer you're in AFib, the more devastating the consequences can be long-term. And so if we can prevent that as much as possible by decreasing the burden of AFib, and I think that's what I try to tell my patients. Yeah, we might not get rid of AFib completely because it is a progressive disease, but if we can decrease that burden from 50% to just less than 5%, that's, you know, a 10 over decrease in threshold. And I think that's significant with regards to the management of atrial fibrillation. So I think it's very, very important from my standpoint as the physician who does these procedures to let the patient know that, yes, you may have a run of AFib here or there. You may have a few minutes or maybe even an hour of AFib, but if you were having AFib episodes almost nearly every day, and now you're having it once a month or 2 times a year, 3 times a year, I think you'd rather have that than be in AFib almost all the time. I hope that makes sense.
Absolutely. Thank you very much. It's a great presentation, by the way.
Thank you.
We have a couple more questions in the chat. Ash, do you want to just ask your question? Ash has some concerns about fatigue. Ash, are you able to unmute yourself? Bottom left-hand corner on the microphone. Click it. There you go.
Off late, I get very, very tired. I'm an open heart surgery patient and had several episodes, but I get very tired. The only way I can get back to normal is having a couple hours of sleep. Even if I take a keyboard and strike something, I get awfully tired. Should I be concerned about that?
Well, has it been something recently that's new? Has it been a certain change in your condition that you can play? I mean, that in itself is still concerning. I mean, just because you've had some kind of bypass surgery or open heart surgery doesn't mean that you should necessarily, you know, have this significant amount of fatigue where, you know, the only thing that can cure you is a couple hours of a nap. So I would say I would talk to your cardiologist. I would talk to your primary care doctor and make sure that we're not missing more common causes for feeling like that. Fatigue, it could be anything as simple as maybe your thyroid is off or something like that. Not everything necessarily is related to the heart. I have to remind that to my patients sometimes. And so first you want to make sure that, you know, from my standpoint, I'm going to focus on the heart, but there are other doctors out there and we should employ them in certain situations in order to make sure that we're not missing, you know, the forest for the leaves, essentially, if you understand what I'm saying.
Okay, thank you.
Mm-hmm.
Very nice presentation.
Thank you.
I have one more question in the chat, but before I get to that, does anybody else have anything they want to ask Dr. Ahmad? No. Okay, so Dr. Ahmad, the last session we had for chapter 94, Dr. Wong, actually you probably know her, spoke to us about the role of artificial intelligence in the future of sort of cardiac care. She's a thoracic cardiovascular surgeon. And she spoke about, and a lot of us found this pretty interesting, that she shared with us the example that perhaps in 5 or 10 years, radiologists are going to be almost replaced by computers and by AI. We all of us found that very, very interesting. So we're curious, actually Norm is asking this question. He feels pretty confident that in your field, you will not be replaced by AI, but could you talk a little bit about sort of what AI would look like in terms of electrophysiology and how you see it rolling out in terms of those of us that are patients of yours?
So first of all, I like the fact that I have great job satisfaction and also have great job security in the field that I'm in. So that's one good thing. I don't have to worry about that as much as, you know, unfortunately, maybe others will have to in the future. But I think if we employ AI in the right manner, it can be amazing. We are looking at whether or not, if we take someone's EKG, if we can apply an equation or a formula to it that AI can employ, whether or not we can in the future kind of see if they are at higher risk or preponderance for some type of heart arrhythmia. And, you know, just based off of their baseline EKG when they're 19, 20, 25, 30 years old, and they go to the hospital and they get an EKG, we can maybe even determine that they're at higher risk just because of the way that the EKG looks, essentially. So that's one interesting factor. The diagnosis of atrial fibrillation and diagnosing it earlier on, that is going to be very, heavily influenced by AI. And I think it's going to be very exciting to see what comes out of all that. I think really the sky is the limit with regards to what we can do with AI, the technology that we have, luckily these days, and being in the field of electrophysiology, which I think is the most science fiction type of procedure field in medicine as of right now. I mean, I put catheters up into the heart, make a 3D map of it, and then I go ahead and ablate atrial fibrillation. I don't think it gets much cooler than that with regards to what we can do. And this is all minimally invasive, and the patient gets to roll home the same day. I mean, who would have thought that even 5, 10, 15 years ago? So, and all these significant changes with regards to pacemakers and things like that, all those things are very, very exciting. And so I'm looking forward to how we can employ AI in order to make it more effective, first of all, for diagnosing a patient with some kind of heart arrhythmia. Second of all, for the financial aspect of hopefully preventing long-term sequelae of these arrhythmias, whether it's life-threatening arrhythmias such as ventricular tachycardia or ventricular fibrillation, or if it's something like atrial fibrillation and flutter, and trying to decrease the risk that we could by maybe even treating it earlier, or telling our patients, if you do this changes, you might decrease the burden that you might have of AFib in the future, whether it's losing weight or, avoiding alcohol as much as possible, things like that, which can help decrease the chance or the frequency of atrial fibrillation. So I think AI is going to have a role definitely in the lives of all of us in different regards. But I think with regards to healthcare, and specifically in my field, it's going to be amazing. And I'm waiting to see what we can and can't do with it. But like I said, I think there's going to be very little that we can't do with it. And I'm excited to be able to employ that, as long as they don't take away the catheters from my hands.
Yeah, I think the last session really got a lot of us thinking exactly about AI, and that was a great answer. Anybody else have any questions, comments, concerns? Well, thank you so much, Dr. Ahmad. I know I learned something every time I listen to you present on this. I learned something new, so I'm grateful for that. So thank you for spending your time with us tonight. And thank you to everyone for attending.